work. Hindgut, foregut, is there more? Well, clearly there's more. We know it works, don't we? We know that bariatric metabolic surgery works beautifully. There's an argument about bringing science to this area that it will fall on deaf ears. Well, I can see silly terms. For long limb Roux-Y, some mini gastric bypasses, BPD, DS, jejunal bypass, there is some malabsorption of macronutrients. But does it help us? Is it a problem? The issues of restriction and the issues of malabsorption are the problems of bariatric surgery, bariatric metabolic surgery. They're not the secrets we're looking for. Why is it hard to lose weight? I'm coming back to weight because that's what's driving a lot of your effects. There are other effects, as you've heard. It's not a matter of willpower that you can't lose weight. It's not a matter of compliance. It's physiological. Look at all these other things that are tried, and they do produce weight loss, don't deny it, but it's very modest indeed. We regulate our energy balance so closely, we can't even measure the differences. None of you sitting in this room really consciously regulate your energy balance. If your weight doesn't change week by week, you're lucky, as long as you're reasonable weight, but you didn't design it that way. Constant energy balance of just 1% would end up with an increase in weight loss. We can't even measure the tiny differences that would be needed to make someone obese. And you know, physiologically, if people lose weight, they have a tremendous urge to put that weight back on. And that urge varies from person to person. It's not limited, it's not the same. And the neurohormonal mechanisms that are causing bariatric metabolic surgery to work, if we take them away, as we've seen with VBG, when it dehist, people go straight back to the same weight. Some quickly, some slowly. So some people have strong springs, but there's very strong reason to go back. Why is this? Well, when we lose weight, we decrease our energy expenditure dramatically. Why do we decrease energy expenditure? Well, we lose lean body mass, we lose muscle. Every single weight loss study shows that we lose muscle along with fat. We've got to minimize the amount. But also we start to move, we start to fidget, we reduce elective movement. We take people who are fidgeting all the time and they lose weight, they stop that. In addition, when we lose weight, our muscles become 20% more efficient at generating energy. We burn less fat and get more miles out of it. Absolutely solid stuff. We also have reductions in body temperature. Any of your patients complain of the cold a bit in winters? It's always warm here. We have reduced sympathetic activity, quite a marked and important point, and we have reduced thyroid activity. All of those things happen as a response to losing weight. Every single factor says, put the weight on, put the weight on. In the weight loss state, we completely change our perceptions about how much we've eaten, our perceptions about how much, are altered about how much it needs to satisfy. We sensitize the reward pathways. We go hunting for food. There's an emotional component to food. It's quite extraordinary, and we can identify all these with functional MRI. So we know the physiology is strong, and we've got central mechanisms that record that. We've got anabolic pathways, catabolic pathways, and in this slide there's something wrong because the gut is missing. The gut is crucial to these activities, a whole range of activities. The control over the appetite and energy intake is very centrally, or is centrally in the brain, but the gut, and we've discussed some of those hormones. And I don't think we should ever move the weight and weight loss and energy balance from other effects of metabolic bariatric surgery. There's just no need to do so. The big thing we don't understand, and we really struggle to understand, is how on earth bariatric surgery can change our setting, and I'll show you how it does that. Body is far better positioned to defend against weight gain than it is weight loss. We have redundant pathways to make sure we don't starve. We know what ghrelin does. Ghrelin stops us developing hypoglycemia when we're fasting. If we don't have ghrelin, we're fine. We live normally until someone takes food away from us and we die quickly. We have defense mechanisms as for weight, for breathing, for blood pressure, for temperature, for blood glucose. all the fundamentals of life, we must have absolute control, and that is going to be within the brain. We have medications that deal with all these things, and the clever fellows that are looking at the gut and doing the science on the gut want to develop medications that they learn from your procedures to do away with you. So weight loss is the perfect storm for weight regain. This is a demonstration, a very nice demonstration from Carl LaRue's sort of model on this and how we reset. This is a lean person, that's their meal size, that's satiety, and the obese person has a different set. They need more food to satisfy, they need more food every meal, and to get that, they become bigger. And they're hungry. They eat a lot, they're hungry. Bariatric surgery of all types, every single type is magic. It does that. Every single type does that. It reduces the meal size to give the same area of satiety. How does it do that? We don't know. That's the number one question we should be asking. How does that happen? What we do is we take someone from the yellow up there and we take them to a completely different. This is a sort of Lee Kaplan model of changing energy balance. We change the area that the person works around. The interesting thing is they defend that bottom one just as they defend the top one. So if you've got a person down there who's happy at BMI 32, take them down to 30 and they get hungry. And they'll push themselves back up to 30. Tell them to exercise, tell them to diet. It doesn't work any better. They have been reset. It's a bit like your blood pressure tablets. They reset you, but you'll still respond beat by beat to a drop in blood pressure. You respond quickly physiologically. You haven't killed the regulatory system by doing surgery. What you've done is in non-surgical weight loss, we have increased hunger, reduced cognitive restraint, decreased inhibition, you hunt for food. Those of you who've been sitting here for a while, if you've lost weight recently and you haven't had surgery, you'll be looking to get something to eat. Surgical weight loss reduces hunger, reduces cognitive restraint, and reduces disinhibition. It does all the opposite things. It resets. How that happens, we don't understand. All of those procedures do it. Every single effective procedure for significant weight loss has a gastric component. So, is it foregut, is it hindgut, or is it gastric? Oh dear, we now have the stomach coming into central play. And this work been shown that pressure is important for the effect of the band, pressure is almost certainly important for the effect of the bypass and the sleeve. There are effects mechanically in the stomach that are important. I saw a patient the other day who'd had a BPD and lost no weight. None. Why? Because they'd had a VBG in the past, they undid the VBG, they'd had a lot of trouble up there, so they didn't do a gastrectomy. They didn't remove the stomach size at all. They recovered that and did a BPD. What happened? Patient eats all day, every day. It comes out the other end all day, every day, but there was no weight loss. So when we look at the mechanical side of things, I'm going to do this briefly. I actually put this slide up last year. Did anyone remember it? There's no hands go up. This is the number of vagal afferents, signals from the stomach to the brain and where they are in a rat stomach. Look where they are, sitting just below the gastroesophageal junction. There's a fovea like there. It's like the pacemaker of the heart. The stretch receptors in the entrance to the stomach are most powerful in the rat. We presume the same thing's happening in humans. And you know, we've got these stretch fibres there. Fibres that tell you what's happening in your stomach. You're sitting there at the moment knowing exactly where your left foot is and where your left ear is. Of course, your stomach knows exactly, it's signalling the brain exactly what the state of your hunger is, what the state of your stomach is. And we're actually altering that with these signals. So my complex diagram, mechanical factors are important and probably important in every procedure we do. But there's more. There's this little thing that you've heard a lot about. I'm saying, yes, of course this improves diabetes, it's terrific. But my main message before is, but does it change the long-term history of diabetes? Is it going to be different in 5 and 10 years? We're not sure, but these hormones are critical. You'll see the L cell production. You've just seen these slides. And we know that GLP-1, does it work directly? Strangely not. Actually, GLP-1 doesn't last very long in the circulation. There's a thing called DPP-4 that knocks it down within a minute or two. People question whether it can even get to the pancreas. The brain produces most of the effects. And you know, if you put some material, glucose, in the proximal stomach, wouldn't you expect satiety, reduced gastric emptying, reduction in glucose production from the liver, and promotion of insulin secretion? This is a smart hormone. It's meant to function. It doesn't function well in people with type 2 diabetes. And we've got PYY. We know what ghrelин's doing. We've got a lot more information, but it's a confused situation. We've got a whole lot of factors that work via vagal afferents. That's messages from the gut to the brain. 85% of that nerve is sending signals upwards. We keep thinking of the vagus as what it sends down. We keep thinking of sympathetics as what it sends down, but it also sends it up. So we've got the nodose ganglion, and you know the nodose ganglion is clever. We have regulation and nutrient sensing in the brain, in the arcuate nucleus. We have it in the hindbrain, the NTS, but we also have a very clever nodose ganglion. In weight loss state, the nodose ganglion changes its production of neurotransmitters. It changes the flavour of hormones. When you lose weight, the nodose ganglion actually increases the production, the expression of the hormones or hormone transmitters that are going to make us hungry and put on weight. So it's a very critical part of this process. And finally, we're learning something extraordinary about the sympathetics. And I mentioned the sympathetics are not just sympathetics out to the body, but sympathetics are part of a very sophisticated nervous system. Your sympathetic activity to your leg, your muscles, your blood vessels, your heart, your kidney, and the gut are all regulated completely separately. They're not just one area of sympathetic tone, and we've found that we can change sympathetic activity quite quickly and change insulin sensitivity, blood pressure, and they all go floating together. So we have a really interesting mix. This was a slide I put up some years ago. You'll see all the offending and interesting things there. You'll see the ileotrans interposition. You'll see the DJB. You'll see the portal vein sensing. You'll see the GLP-1. But as Ricardo says, we're learning more. We've got the gut microbiota, which are really, really interesting. We've got the whole story of the bile acids and their transposition through the bowel, their routing around. It's really quite an exciting area. But does any of this, which of this has an effect on energy balance? We don't know. And do these have effects on long-term natural history of diabetes? We don't know. So, my conclusion, the gut holds remarkable keys to controlling energy balance and treating metabolic disease associated with that. Do not put your weight loss down as to being not important. It's great for the scientists to debate, but weight loss is really important for the majority of your patients. Interaction between the elements of the gut, physiology, stomach, foregut, hindgut, they're all interrelated. People spend their lives studying the enteric nervous system, and of course they're all interrelated with the brain. Additional specific effects on diabetes or lipids or hypertension are unclear at the moment, and we've got numerous putative mechanisms that might work. All interventions, whatever we do, has upsides and downsides, so we've got to be very careful about what we do. If we alter a hormone in the body significantly, we're doing a whole lot of things, not just one. If we increase growth hormone to improve our performance on a bicycle, it may have effects outside that. And testosterone, growth hormone, ghrelin, all of these things can have important effects. So the lack of clarity in this area is critical. We need to be very careful about how we approach innovative surgery, new surgery. We need to go it in a process that it goes from phase 1, phase 2, phase 3, as we see is happening particularly in the South American groups. They're doing beautiful work, but we've got to be careful. Let's not rush into translating any of this into humans before we really know what's going on. So just to thank my team. They're very good thinkers about these problems, and believe me, from people who are very good scientists who come from an outside bariatric surgical world, they are very clever at giving us insights into what may be happening. So I love to talk to people who are outside the space. They really they think very well. Thank you.
Thank you, Thank you, Professor. I think we will start now the coffee break, please. join us. We are going to start our new session of debate 3 with Dr. Lee regarding predictors of success after metabolic surgery. Please.
Okay, good morning. First of course, we should thank Movi to hold this great meeting. And I think we can learn a lot from the expert. And for this debate, I think it's just a review, not really a debate. A predictor of success of metabolic surgery. Bariatric surgery, I think, is an effective procedure for controlling morbid obesity associated with diabetes. And remission is a decrease in metabolic surgery in low BMI, as we know. And I think the information of predictor of success after metabolic surgery is important if we are going to apply this treatment for this group of patients. Yes, of course, everybody is known with this. Weight loss is very close related to the remission of diabetes in morbid obese patients. However, you can only have the weight loss after surgery, so it's very difficult to predict before the surgery for individual. So what we have, I think Dixon had made the first announcement of some predictor in his old paper, in the bending paper. You realize some old patient and patient with a longer history of diabetes and severe disease, that means you use high dose of insulin and poorly controlled DN, like the high HbA1c that may accelerate the beta cell failure. This factor had been repeated in many papers thereafter. And I'm only concerned is one is the use of insulin, because the use of insulin is usually decided by the endocrinologist, and it varies from area to area and the attitude of endocrinologists. For example, in Asia, most of the Asian patients don't want the injection, so we are using insulin very late. So in this indicator, probably is not a good one in some area. So I think this is the paper the Dixon have just mentioned. So in there, after a large cohort and the multivariate analysis, we can see some independent factor, the BMI and the duration of diabetes and the C-peptide. And these three factors come out to be the most important independent factor we have now. And this is to show the response rate is different quartile. And as we can see, the most beautiful presentation is related to the duration of diabetes. You must have a very short duration to have a good remission rate. Otherwise, if the longer than 5 years, it probably goes very low responses. And also the C-peptide. C-peptide is equal to insulin level. I think now we know high insulin resistance is also a good predictor for the decrease of mortality after this kind of treatment. And BMI, of course, some study in supermorbid or morbid obese literature showing BMI is not independent. However, if you include the low BMI patient into, you will see it become an independent factor. Why? I think because the duration of diabetes is really reflect of the natural course of this progression of diabetes. And also the temporary success after bariatric surgery may have some reverse in the longer follow-up. So we really need a longer follow-up to show the bariatric surgery now can really provide a durable remission in this group of patients. Again, I want to show duration probably the most important factor now we have. You can see so many papers to analyze all of most factors. Although duration is not a very reliable, but at least it is the best now we have. Duration reflects the natural cause of diabetes. So the longer the duration of history probably reflect the poor indicator of this kind of treatment. So in our series, you can see the duration. It's quite interesting to see the two different procedures. In restrictive groups, that means spending and probably part of sleep. Less than 2 years is very important. Once you go up to 2 years, then the remission rate drop quickly. However, in bypass groups, it's not decreased so dramatically. However, you still can see it deteriorate with the longer duration. So in our previous study, I support this bypass group exclusion duodenum really have some factor, probably 30% of a factor, and 70% is related to the weight loss. And I would still think of the C-peptide, because C-peptide is reflection of the beta cell mass, and it's equal to the insulin level. However, it can avoid some confounding factor in the insulin level. If a patient have insulin usage, sometimes it's difficult to use insulin level directly. However, if you apply C-peptide factor, you must realize it will be influenced by the kidney function in some patients, and also the glucose toxicity may influence your C-peptide. So in that circumstance, you probably need to do some function study, like stimulate the C-peptide to make sure the real beta cell preserved. So in a very low BMI patient, Dixon has showing we have a study to look at specifically this group of patients, and the result is not very promising. The remission rate probably is only, I think, less than 40%, and still duration come to an important factor. And weight loss still is, even in this group of patients, is still play a significant role, and C-peptide as well. And again, this is the remission rate according to the quartile of this group of the patient. And you can see the remission rate is relatively lower than the report from higher BMI patient. Even in the lowest score, remission is only about 50% in the short duration of the duration diabetes. So you will expect a lower remission rate in very low BMI patients. Yes, and you can see the decrease of the A1C is really associated with the weight loss. I think you still need to have some weight loss to have a durable remission. However, the durable weight loss probably is related to the gut hormone we created. So I think these two is not against each other. And this is to show our more updated data. And we have a cohort in Asia. We now accumulated, I think, more than 1,000 low BMI diabetes patients. And we follow up, we hope to have a long-term follow-up data. Up to now, you can see when we divide the remission rate according to the BMI, you still can see in Asia population, if BMI over 30, the efficacy of metabolic surgery is equally to those with 35. But if you go under 30, the efficacy is significantly decreased. Okay, and the second is the age is quite interesting. If you have a good enough group of patients, you can see the difference vary from the age. in the young age, the reduction of A1C is much higher in those of like old age. So when you apply this surgery, I think age is also very important. We probably need to avoid this surgery in very old age patients. Okay. And more interesting is the procedure. A comparison of different procedure is pretty difficult because most of the result is retrospective, and some randomized trial is a very small group of patients, so it's not easy. But according to a review article, we can see the bending and the DJB probably associated with lower reduction compared to other procedure. And between the bypass procedure, there's really no much big difference. And for the new procedure, they have just mentioned in the sleeve capsulectomy and the intestine transport position, you can see the role of duodenal exclusion is important in all this kind of study. If you exclusion the duodenum, you will have some benefit from exclusion of the duodenum. So the randomized trial for Dixon, okay, is a limited in very short duration of diabetes patient. That is only criteria you can have a better result as Dixon in this randomized trial. And let's see, we have to do a review article. Up to now, I think in this paper we review 19 randomized trials. No one surgical treatment arm is worse than the medical treatment, no matter what kind of intervention method you use. So we do believe our surgery can do better than the medical treatment arm now. But you look at the precision randomized trial, no difference in the two randomized trials comparing LUI and sleep. But in low BMI patient, in my study, we do see difference. I think this is confirmed by another randomized trial from the Showers group. So in a low BMI diabetes patient, I think LUI is better than sleep. So this is our randomized trial. We can still see the weight loss is quite similar between, but the A1C difference is starting from the 1 month, and now we have the 5-year result, and the trend is maintained up to 5 years. And this two randomized trial, I think, is very familiar for everybody. Again, I will show in a Shire study, it's almost exactly like ICE. The weight loss is similar. Although the A1C is not different, but the using of medication is totally different. And the second year report from Shower has shown the difference become more significant between these two procedures. And for the mean growth study, I think the mean BMI in this study is 46. So probably it's only in morbid obese patient. You can see the BPD is better than bypass in this group of patients, but there's a higher instance of malnutrition problem in the BPD. So the last I want to raise is when you look at the different paper, actually there's a very different in the patient group. Majority of the report is from morbid obese patient. The diabetes is just a standby disease. So when you compare this group of patient to the other group of patient, the patient is come from diabetes treatment, not obesity treatment. The story will be totally different. So we try to propose this score so we can divide our patient into different scores so as we can compare each other and have a more clearly outlook in the future. So we include the 4 factors I have just mentioned, the age, BMI, and C-peptide, and duration of diabetes. And now we have more than 1,000 cases. We can see when you have more cases, this kind of staging system plays really good. So the remission rate in different score, you can see it has a very linear relationship with your score. The lower score have a very low remission rate, and this can be observed on the same trend up to 5 years. And if you have a very high score patient, then you can expect very high diabetes remission rate. This can help. So, ladies and gentlemen, my conclusion is Metabolic surgery is an effective treatment for not well-controlled obese diabetes patient. Duration, C-peptide, BMI, age, and the type of surgery predict the success of metabolic surgery. And weight loss and maintenance of lifestyle modification are also important. Thank you very much for your attention.
Thank you, Dr. Lee. For the prediction of failure after the metabolic surgery, I would like to invite Dr. Shala Sheikh for giving her speech. The next two sessions will be delivered by my colleague, Dr. Yogesh.
Good afternoon, everybody. At the onset, of course, I would like to thank Mufi and his team for inviting me to this lovely venue. I actually felt like royalty when I entered. It was a fantastic experience. When Aparna first gave me this topic, telling me, ma'am, you have to talk about predictors of failure of metabolic surgery, I told her this is the first time I'm going to be talking like an endocrinologist rather than talking like a bariatric physician. Basically, we all love success stories. I'm standing in a room full of people who vehemently believe in metabolic surgery. I am also one of them, believe me. But at the same time, I think we need to temper this enthusiasm somewhere and understand there is also a flip side to it. From morning, I've been hearing about lovely lectures about theories, foregut, hindgut, whether it's a gastric theory, and lots of data I've heard from morning. What we don't talk about in any of our meetings is which of our patients do not do well. And in this context, I'm not talking about the SOS study. I'm not talking about long-term data where your patient is going to relapse after 10 years. I'm talking about your patient, you've done a surgery, and for some reason, 3 months down the line, 6 months down the line, your patient is simply not doing as well as your patient should do. Initially, when I did a search on this topic, every time I would do a Google or I would do a Medline search, the com would turn around and tell me, do you want predictors of success of metabolic surgery? The data about predictors of failure is actually so minimal. We simply do not want to talk about where we are going wrong. I agree metabolic surgery is the most efficient treatment for obesity. But what I also need to put across is that 15 to 20% of our patients fail to achieve adequate weight loss. Why is this so? Is it patient-related factors? Is it surgical-related factors? Are these metabolic factors? Where exactly are we going wrong? We are all familiar, 77% resolution. We have all sorts of wonderful numbers as far as resolution goes. But what about that 20 to 30% of patients who are not doing well? Where is it that we lack? If you look at predictors of failure, is it the age? We are BMI centric as far as surgery goes. We only talk in terms of BMI. As one of the earlier speakers pointed out, the reason we talk about BMI maybe is because it is more easy, more convenient. A uniform thing, anybody, anywhere can use it, does not require too much of cost. Maybe that's why we talk more about BMI. But I think as a group, we need to go a little more beyond BMI also and think in terms of whether there is some other parameter which we can add. Are we justified in talking in terms only of BMI, especially since this is basically an Asian conference? We all know our BMIs are different. We all know we are much lower BMIs. And we all know that we are actually the thin fat phenotype. We are all very, very familiar. Dr. Yagnik's slide, I think, is a universal slide, which we see all the time. So are we really justified in talking only in terms of BMI? Physical activity. My patients believe that once I've done the surgery, I am fine. I am going to do great. I will talk a little more about detail about that. Eating habits, post-operative status, and of course, psychosocial factors which play a very, very important role. The previous speaker has already alluded to the fact that patients at extreme of age may not do very well with surgery. You would need patients in the mid-age would do best, the reasons which we will get into. Similarly, very young age and immaturity are again poor predictors. Super obesity can be a poor predictor of surgery. Patients suffering from morbid obesity had a 2.6 times higher risk not to have a success than those who have severe obesity. As far as physical activity goes, my dietitians would vouch that the patients feel that, oh wow, first year I've lost fantastic weight, I'm doing great. Initially, the excuse is, I'm not exercising because I'm overweight. Once you start losing weight, the excuse is, why do I need to exercise? I'm either way doing fine. So the bottom line is that the patients also need a lot of motivation to understand that it is an ongoing process. Metabolic surgery is only part of the process. It is not the end result. It is not that it is the panacea of all ills and once you do metabolic surgery, that's it, the end of the road. Similarly, there's no change in eating habits. Almost 20 to 25% of our patients do indulge in some form of binge eating, which persists, especially at the high-end patients who feel that, no, I've done a surgery, it's absolutely okay. The patients will keep on having their high-calorie diet, and then the complaint is, why is my diabetes not resolving? You told me that it would go away after I did the surgery. The most important thing which I think you need to do is psychosocial evaluation. A lot of our patients do have substance abuse or poorly controlled psychiatric illness, and this needs to be evaluated before surgery. We have no excuse for not evaluating this, especially substance abuse. We see a lot of alcohol abuse. On the way to the hotel also, we were discussing in the car that how much of alcohol abuse we are seeing, and it is increasing day by day, and that is the experience in the Indian subcontinent also, especially even post-surgery. So these things have to be looked after pre-op, so that we do not have problems, then maybe in the next meeting we could say that we are having 100% resolution rates because we are doing such a fantastic pre-op counseling of our patients. This is as far as the patient factors are concerned. This is where the patients would contribute to the failure of the surgery. What are the other factors? The medical factors by data is that open procedures, male gender, patients with CCF, peripheral vascular disease, DVT, obstructive sleep apnea, impaired functional status and chronic kidney disease do not do very well with bariatric surgery. There's enough data to say that these patients are patients who need more care, and these patients may not show complete resolution of the diabetes or other metabolic factors. The surgical factors we also already know, so I will not go into the details. What I'm really interested in talking is about the metabolic factors. Dr. Lee has already alluded to the fact that duration of diabetes is very important. As an endocrinologist, I would like to add the duration of diabetes is actually the time from which the patient is diagnosed, which may not be the actual duration of diabetes. The day the patient is diagnosed is the time that you and me know that this patient has diabetes, but this patient, as we all know, 50% of our type 2 diabetic patients are asymptomatic. They have absolutely no symptoms. So they could possibly be diabetic much longer than what we are seeing. So instead of us talking only in terms of duration of diabetes, should we be using some other parameter at that point of time which would give us a better input as to what exactly the pancreatic function is like at that point of time. Also, poor glycemic control. When we're talking in terms of poor glycemic control, we are talking about patients who have an HbA1c of more than 7 persistently. I mean 6.5 to 7 is what is accepted without any other complications because of therapy. So if your patient is not there, this patient is at risk of complications. The reason we need to treat diabetes is so that we can reduce the long-term complications. That's the main aim of treating diabetes. Otherwise, a patient with a HbA1c of around 7.5 either way has no acute issues arising in life. But what your aim is that you prevent long-term complications, and then you need to be able to identify these patients much earlier than what we are conventionally doing. Then we would be able to reduce the failure rate. Then we would be able to really make a difference as far as our patients go. Among 468 patients undergoing the Roux-en-Y, elevated preoperative A1C was associated with elevated postoperative hyperglycemia. Absolute weight loss is actually negatively correlated with preoperative treatment for type 2 diabetes, but not with the biomarkers of type 2 diabetes or insulin resistance. Similar data from Chikuguwo, who saw a 5 to 16-year follow-up on a series of 177 patients. 89% complete remission, 11% did not remit, which is interesting, despite a mean excess weight loss of 58%. So you have a group over there. We were talking about weight-dependent, weight-independent factors in the morning. So you have a group over there who does not remit in spite of weight loss and who subsequently developed recurrence of type 2 diabetes. And what is interesting is that weight regain is not actually very, very statistically significant for this. So maybe it's a story beyond weight. Similarly, another study, Georgi, showed that patients, though they regained a greater percentage of the lost weight compared to those who do not experience a recurrence, Even then, weight was not the only factor involved. So what is the factor involved? It was seen very, very conclusively that fasting pre-op C-peptide levels had a better predictive power. 90% of type 2 diabetic patients with pre-op fasting C-peptide more than 1 achieved a post-op HbA1c of less than 6.5, whereas 74% achieved complete resolution of the diabetes. But if there was a C-peptide of less than 1 nanomole per liter, the patients did not achieve these goals. So we have to, by the rule of the thumb, incorporate C-peptide levels in all our diabetic patients. Because C-peptide is a surrogate marker of pancreatic beta cell mass, and clinically what we use is a C-peptide of more than 3 nanogram per ml to be the most important predictor about whether your patient is going to do well or is simply not going to do well on surgery. What about the other GI hormones? Conventionally, we do not do GLP-1 levels. We are planning to start doing it in the next 3 to 4 months. But at this point of time, it has been seen that in patients with poor weight loss after gastric bypass, associated with increased appetite, it is the postprandial PYY and GLP-1 responses which are attenuated. So these responses are reduced. Inhibiting gut hormone responses results in return of appetite and increased food intake. This is one of the reasons where post-operatively we use DPP-4 inhibitors, because that is one of the ways in which in most of our diabetic patients post-op, when we are sending them home post-surgery, we are shifting them to DPP-4 inhibitors because that does improve their GLP-1 levels and that does give us better control of sugars post-operatively. The other entity is LADA. I think LADA is much more common than what we realize. The problem is it often simulates type 2 diabetes. Just clinically, it is practically impossible for us to differentiate between LADA and diabetes or type 2 diabetes, and that's why we often goof up, and maybe some of the patients who are not doing well, some of the patients who we feel are slowly progressing could actually be LADA. It would be interesting if we could do GAD antibodies in all our patients whom we are taking up for surgery and see the incidence in our patients and find out what is the incidence of LADA in our subcontinent, because it is these patients who would slowly progress to becoming insulin dependent, and these are the patients who would not do very well with surgery, and this is the group which would have, though initially has greater beta cell function, there is progressive deterioration of the beta cell function, and finally this patient does become insulin dependent and behaves similar to type 1 diabetes at some point of time, and that's why it is conventionally called as type 1.5 diabetes, neither type 1 nor type 2, but it behaves somewhere in between. What did our study at CORD showed? It showed that Roux-en-Y stands the test of time. The median excess percent weight loss at 5 years, 67.8%. We all know this was published data. What I want to point out is that 3.8% had no remission. Because I'm basically talking about that percentage which has no remission, so I'm going to talk about that group. And we found that that group is the group which had a fasting C-peptide between 1 to 3. The patients who did well were the patients who had C-peptides between 3 to 6, and the patients who had C-peptides of more than 6 had 100% resolution. So your C-peptide can be a very good surrogate marker for which patient of yours would do well with surgery. And patients with shorter duration of diabetes did better, 100% remission, 5 to 10 years, 28% complete remission and 72% partial remission, and above 10 years, 48% had no remission and 52% had partial remission. So I think we really need to think out of the box. We need to understand that if your duration of diabetes is long, of course there's going to be failure. Type 1 diabetes, as we all know, there is going to be failure. Compromised pancreatic beta cell function, C-peptide less than 1, again failure. Inadequate weight loss due to all the reasons which we have alluded to, again failure. And of course, lack of endocrine and nutritional support. This has to be a team effort. You cannot survive without your nutritionist and of course without your endocrinologist. So in keeping that in mind, you need to see that your patients have less failure after surgery. So basically you need a multidisciplinary approach, and I really feel if we look at it from out of the box and start looking at our patients differently, we would go beyond BMI. Thank you very, very much.
Thank you, Dr. Shaila, for such a wonderful presentation. Good afternoon, ladies and gentlemen. All of you would agree that we are so fortunate that physician and endocrinologist colleagues are now vehemently supporting bariatric surgery. albeit with some caution of the bumps on the road to surgery. Well, going on to the fourth debate. The previous debate was between a physician and a surgeon. We're restoring normalcy again. Now, two surgeons, the veterans at that, would be debating the next topic, and which is surgery for type 2 diabetes mellitus in BMIs less than 27.5. And who would be the better persons than Dr. Wilfred Mui and Dr. Harry Frydenberg? I would invite Dr. Wilfred Mui first to talk for, and then Dr. Harry would talk against this subject. Dr. Wilfred, please.
Thank you. So before I start my speech, I would like to thank Mufi for the kind invitation. This is my 5th time here. I missed the conference last year, but so I'm glad I'm back here. So today, the topic is a debate whether we should operate on patients type 2 diabetes with very low BMI patients. Of course, I am talking in the context of Asians, East Asians in particularly. And of course, I'm not debate with Harry whether we should operate for Australians, okay? So, disclosure, I have nothing, but except I'm a great proponent for surgery for metabolic surgery. This is just to recap what the consensus right now. This is the paper published by Kasama back in 2 years ago. This is the paper that was drafted by Kasama after the conference in Japan. Harry and I were also the author, and we come about the consensus that, in fact, for Asians, if you have a poor control diabetes, now it's quite acceptable to operate if you have a BMI more than 27.5. I don't think we have any disagreement on this at the moment of time. But there are a lot of more evidence and paper coming up after that. And I just want to list up some of the landmark and most important paper for the past 2 years. I think we all know about this paper from the Cleveland Clinic, Dr. Shaw's randomized trial comparing surgery with medications. In fact, in a group of diverse patients as low as BMI of 27, corresponding to class 1 obesity in class 1 obesity. And I think we all know about the results. No matter whether it is in hemoglobin A1C, fasting glucose, number of medications, and change in BMI, bariatric surgery proved to be effective, better than medical therapy, at least in short term, in a randomized controlled trial. This is one of the very well-designed RCT. Another randomized controlled trial just published this month by a diabetes surgery group, published in JAMA. This is another paper regarding Roux-en-Y versus intensive medical therapy on low BMI patients, BMI more than 30. And similar results, in fact, no matter whether it is in terms of weight loss, hemoglobin A1C, LDL, and systolic blood pressure. In fact, surgery is much better and effective than medical therapy. So at least including Dixon's lap-band RCT on low BMI patient, at least we have 3 very well designed, conducted RCT regarding surgery compare head-to-head to medical therapy in a randomized control study, although it is just a short term in terms of 1 to 2 years follow-up. And we have even a systematic review just published this month in JAMA regarding surgery for non-morbid obese patients' diabetes. The conclusion is quite evidence that even for surgery, it is better than medical therapy in terms of short-term outcome. Although the author doesn't recommend surgery as at the moment of time, but in fact we are quite a lot of evidence that surgery works even for non-morbid obese diabetes, at least in short-term follow-up. What about in Asia? Okay, so this is a paper published by Professor Lee and gathered results from different countries in Asia, including Hong Kong. And Dr. Simon Wong was also one of the authors, Kasama and Murphy. Okay, so what Professor Lee is analyzing about 200 patients of diabetes undergo surgery. This is the results. In fact, if you look at the BMI, even for very low BMI patients, BMI 25 to 30, the remission rate, although it's not as good as the higher BMI group, up to 78.7%, but even for low BMI patients, the remission rate is very remarkable. For even less than 25, is up to 55.5%. And also, in the past 2 years, there's a new concept coming up. In fact, when we look at the remission rate for treatment for type 2 surgery, BMI is not the only criteria. And Professor Lee just pointed out in the previous talk that apart from BMI, there are a lot of other predictors in determine the outcome after surgery. So it is quite illogical and not appropriate. We just exclude patients for diabetic surgery treatment just based on BMI alone. So people say, well, we don't have long-term data, we should not operate. Okay, but we have some at least midterm data coming out. I'm so glad that Dr. Ricardo Cohen is here, that he just published his Roux-en-Y midterm 6-year risk follow-up for low BMI patients with dramatic results. Okay, and Murphy also published his Roux-en-Y effect on low BMI patients. Okay, and published in SOAR up to 5 years follow-up with which is shown that at least in midterm surgery is effective even in low BMI patient. So I just reviewed my sleeve gastrectomy result, and I just complete my 5 years follow-up, and I will publish this paper this year. We have more than 120 patients for class 1 obesity, 25 BMI to 35, and 38 of them are diabetes with class 1 obesity. My remission rate at 5 years follow-up is up to 51.5%. Well, you say it is not as good as in our heavier patients, but in fact, it's still very dramatic up to 5 years follow-up. If you're still not convinced that class 1 diabetes with class 1 obesity with diabetes, we should operate on them. That's why we have another group from Germany. They are now conducting a long-term randomized trial comparing the endpoint of diabetes. And I think in the next 5 to 10 years, we will have more and more results. If you still not believe that we should operate on this class 1, type 2 diabetes, let's look at what we have right now, current therapy. Okay, this is the ADA position statement regarding medical therapy. This is a very, very complicated slide. Okay, it's a logarithm of how we treat diabetes by medicines. Okay, we have at least 6 group of medications, and for most surgeons, we don't know what it's all about. Basically, if one medication doesn't work, we add another one. If 2 doesn't work, add another one in different combinations. It is so complicated for physicians to follow and even for patients to follow. And what's the results? Okay, in fact, for the past 10, 20 years, we have a lot of new medications, but our diabetic control is deteriorating. This is the NHAES4 study compared with 3. In fact, only about 37% of our patients on medical therapy is able to achieve a good HbA1c less than 7. In fact, 2/3 of our patients, in fact, are not reaching the ADA HbA1c goal. And what about in Hong Kong? We do a cross-sectional study of 5,000 patients of type 2 diabetes. The mean HbA1c is 7.7. And on this study, we published in Diabetes Care from one of the endocrinologist group back in 3 years ago. If you look at the ADL goal, regarding HbA1c less than 7%, only 37% of our patients able to do this, okay? If you combine the blood pressure and the lipids together with HbA1c, only 5% of our population is able to reach the goal. This is long-term data, okay? We have proven medication is not working in the long term because only 5% is able to reach the goal. So to me, as a surgeon, it's quite logical. If your patient is failing the medical therapy, if you ask them to insist on medical therapy, and I think it's definitely a failure, even in long term. Because this is the natural history of diabetes. No matter what we do, whether it's invasive therapy or traditional therapy, type 2 diabetic control will decrease over time. And I don't think it is immune to surgery in addition, but I think surgery can buy time to avoid this deterioration. And what about our patients of diabetes? On average, for Asians, our average BMI of type 2 diabetes is only 25.5. The blue bar is our average BMI of all our diabetes. If we exclude surgery for just based on BMI alone, we actually we exclude most of the patients that it may be beneficial for surgery to exclude them from surgery. So my conclusion is, okay, surgery, at least in appropriate type 2 diabetes patients, even in class 1 obesity, we have at least 3 randomized controlled trials. At least short-term to mid-term is better than medical therapy, okay? We know that there are a lot of different factors affecting outcome of metabolic surgery, and to me, it is absurd to just based on BMI alone to select our patients, okay? Well, if you still not believe in surgery, don't believe in medication too, because we know it's quite concrete that it's a failure in long term. It's only about 5% of patients can reach the goal. And to me as a physician, it is illogical and unethical to completely exclude the patients for appropriate surgical treatment for even non-obese diabetic. If the patient failed one therapy, why try? And if you ask them to insist on that, it is kind of illogical. But having said that, we are not saying we should operate on every patient, okay? We still have a lot of things to learn, okay? But at the moment, my approach is we select patients who are poor control diabetic, who have failed the medical therapy, okay? We exclude the other type 1 diabetic, okay? We try to select the patients with good pancreatic functions. Of course, we have to have good informed consent with long-term monitoring. Thank you very much.
Thank you, Dr. Mui.